I'm Dr. Bill White with the American Orthodontic Society, and I have a case here this afternoon that to me is most interesting, and it's just a world of this type of orthodontics out there that's going untreated simply because people just they really don't know how to do this, or they haven't even thought about doing things like this. And you mix orthodontics with all types of dentistry, like restorative dentistry and the temporal mandibular joint problems go together, and then frequently you'll have periodontal problems with adults, or missing teeth and tilting teeth, and anything you can think about. But a lot of these people want to get their teeth straightened up and everything fixed up, so they've got a good dentition there to go through life, and it looks much better. And there's a lot of this out there. So if you learn how to do this, you'll use it in your diagnosis. And most people don't even think about this type of thing when they're in their diagnosis, telling people what they need to do to fix something up. Well, this is a nice guy here. I'm going to have to get this little pen going again, and so we can draw on the picture with it. Anyway, here he is, a very nice guy, and willing to go along with you on all sorts of things. And his dentist that referred him in was a good friend, and you want to work with other people and let them come in and work with you. And if you have to get 2 or 3 people in, or maybe 3 or 4 in on a case, like having an oral surgeon, a paradontist, and maybe an endodontist, and then you do the orthodontic part and let these other people do their part of the work. So I'm going to kind of show you a little bit about that today. Nice guy, smiles, everything. And if the best I remember, he had a mild temporal mandibular joint problem, and not a severe one, but his jaw is locked back, you see. He can't bring his jaw forward, so he chews and pushes the condyle back up in here. He'll push the condyle back up against that retrodiscal tissue, and that's where you get the problem. The vast majority of this TMJ stuff is just a jaw position. And if you can get the jaw functioning in the mouth where it really wants to and it's comfortable there, many people don't. It'll cure their TMJ problem, even though they may have a stressful job, like the guy I showed here last week. Had a very stressful job, but when we got his dentition where it didn't have any problem with that, he was able to cope with the stress he was under. And so this is something we have to think about. So now here we've got a deep bite case. There's no question about it. The lower teeth are way up in, I'll show you from the other side on the models here, and they're way up in there, and it's a class 2 relationship, and so we need to bring the bottom jaw forward. Now he's wearing a partial that somebody made, and this tooth is leaning some here, and because I had to use that partial in helping me open the bite, I did not straighten this tooth out. I kept it, or just left it like it was, and so it's in the finished partial that they had. I regret not straightening that up, but I couldn't have used this partial he had to help me open the bite. And it's very difficult to open a bite where you don't have any posterior teeth. Now the other side, we don't have any posterior teeth over there, and that was the stinger in this case right here. You have to kind of figure out something to do that in doing this type of case. Now this was back in 1990, about 11/13 of 90, so it's almost 91. And here's the other side. And from the bicuspid back, we had nothing. And these teeth, he had just had these out not too long before this, and they would try to start down, so we have to work on that. Now, we've got to get force in this area to bring these teeth in the lower arch down. And so what we did, we put pads out here and let them chew in this area and left this alone, and these erupted up a little bit, and I put something under these to keep them from dropping down while we got the lower anterior to level out. The right side of the mouth wasn't a big problem. The left side was a problem, and that's hard to deal with. If you put an implant in over here, then you can't move the blooming thing. So you could do that, and I kind of thought if I had this to do over again, I would try to get a implant back in here, even though I would have to deal with it. I have to figure out exactly where I wanted it before we got started. Then you could work off of that and bring these teeth down. Now we've got TADs nowadays, and you could put TADs in here and pull the teeth down and level the arch too. So there's a lot of different approaches to it. That modern stuff helps out a great deal. Now you look at the upper arch, there's no big problem with little rotations and things like that. This crown tooth over here, and this one we don't have to line it up and rotate some teeth and do some things like that. Kind of change the whole shape of the upper arch, and none of that is difficult. It's just part of the orthodontic part of it. Now the lower arch was formed and kept in shape with the partial that he had, and we had to put up with this leaning tooth right here because this partial fit on that, and this went back, and we put pads on that to help push that, keep those upper teeth from dropping down while we were trying to intrude these right across here. And it's this was not an easy case, and even though I think I know what I was doing, but it was a tough case to do that. Now here is this old partial that the guy had, just a bar coming around behind here, and we're going to finish, and we'll make a partial that is a partial retainer as well as a partial denture that we put in there. And you could do that several different ways. I just the way we did it. Now looking at the models from the back side, you can see where the lower teeth went up like this, you see. Now we were able to bring this side down pretty good, but it was this leveling it and then keeping these teeth from dropping was the problem that we had. And it turned out relatively good. It wasn't bad. It looked pretty good when we got through with it. I was amazed and even proud of it. So now the jaw needed to come out where this cuspid was hitting here. So we're going to bring this jaw forward, and that's going to relieve the condyle back here that's in the fossa and is pressing on this the retrodiscal tissue there where your synovial fluid is formed, and it's got lots of vessels and a blood supply and everything, and you can't put a lot of pressure on that. If you do, if you got somebody that's got a tough one, well, they might be able to get by with it, but most people will have some problems with them. And you can just bring the jaw forward on these cases, and 90% of them seem like just get over it. If you put the jaw out here, let the jaw close where it wants to, it'll be closing out here. And then you make it where the teeth fit and interdigitate in a place where the jaw is comfortably functioning there. Alright, so here, both sides, this is not as far back as the other one right here, but this needs to come here. And these other teeth, you can see, need to fit together back there. Now, this is a first Panorex that we took, and you see this angle, and I feel bad leaving it. It's so simple for me to straighten one of these up and bring it forward in here that if I hadn't had to use this partial, I probably should have just made myself a little saddle deal with a wire or something to go across here and got rid of that partial that he had. But then the dentist I was working with may have made that, and I have to keep them happy while you're doing this. So I worked with him good. Now we did everything we could to intrude these teeth out here. We built a pad, and I put a pad on the upper teeth and just stuck this on there temporarily to let him chew on that. And then we put where we took this out, of course, and then these teeth would come down and touch that acrylic, and we had these in contact over on this side, and we were able to level the bite out really pretty good, you know. And so we'll come in, we had an intruding arch wire on this. You see this wire right here was way up here. We brought it down, it's picking these up. And it was no problem to lower these over here, but I had nothing to work off on the back, so lowering this was a little more difficult over there, letting them teeth them up then. So I'm kind of going over a bunch of these adult cases so that people will realize that you can do just almost anything. If you can just think up in ways of getting it done, you can move the teeth all over the place. And it doesn't matter. This guy's 50 years old, something in there. I didn't pay one bit of attention to whether it was 50 or 25 or 18. And this old stuff, you know, adults don't move and all this kind of stuff. I think you could straighten people's teeth into their 90s. I'm that old now, and I think my teeth I could straighten them out if I just wanted to, you see. So anyway, we'll pass that on there. And so here's the way we level this out. And we use this little bonded block system up here, and he couldn't close anywhere behind this, and he had to chew his food here. And when you do that, you're biting in the front of the mouth, and there's nothing hits back in here, and then the condyle is up here, and so it's taking the load, and these teeth are taking the load, see? And that's where, if you don't have a good jaw joint or a good tissue back there, you have to be very cautious. You have to put your load down in this area, you see, to finish the case up. So that's one thing. This guy had a pretty tough jaw joint as far as I can tell. No, he didn't have any problems. All right, here's the old partial. See, just this bar going around. A while ago it looked like it was sectioned, but that was this Panorex machine I have. You have to cut the center out. And so we added on to these teeth to put pressure on them to hold them in place. and we put pressure on these to intrude them, and we put something on the tooth over here to level this out, and then we're going to discard this partial, this whole thing, and make a partial that is kind of a retainer and a partial at the same time. And you'll be able to do that, or you can just have your lab man do that. And this is that pad down. We were using little single brackets, and this is the intruding wire, and that was your regular flexible wire in there where we're opening the bite. And it doesn't matter whether it's a upper or lower. We can, if you've got back teeth back there we can get hold of, we can open this near anybody's bite. It doesn't matter. And by using these blocks, I can open a dental bite on somebody that has a high angle or a open bite skeletally, and not open it anymore, and sometimes lower it in the process of intruding the anterior teeth. Put enough pressure that you can intrude these molars back here when normally they would be extruded. To do this to the anterior part, it's going to have to put force on the lower and upper molars to push them together, and that's where people get in trouble with high angle cases. They push these together, and then that you open it a couple of millimeters back here, maybe 4 or 5 millimeters up in the front of the mouth when they get that open appearance there. It does not add to the beauty of the finished product, I'll tell you. Okay, here's just another view of that. Now we use some class 2 elastic of force to bring this out. In other words, this jaw's come forward this much. So if we move this forward, maybe we brought this back a little bit, but not much. And we have these little deals here where we just put class 2 elastics over here. Now it's hard to do the class 2s over here where you don't have any teeth back in this area. You can hook and put your partial in and then wear a class 2 elastic off the partial, and that works, and I've done that on some cases, but it's not ideal by a long shot. Now, okay, here this cuspid is in place, and let me rush on through it. We've got force on these teeth, holding them up in that position, and we'll make another partial for him, where I didn't. His dentist that was working with me, I had to show him exactly what I wanted to do, and he was good, went along with it, and he made this partial, or he sent it to a lab and had the framework made, and he finished it out, and we rotate this tooth and do all the good things you do in just a regular orthodontic case. Now there's the old partial, and this is 11/13 of 90. That's the first cephalometric we took, and that's the first Panorex. There was number 1 over here, see, and he was age 49 and 2 months at this time. That was 1990, and I tell you, there's very little of this that's caught on. I've been lecturing on this and talking and showing it everywhere, and there's a very few people that I know that are doing this adult orthodontics like that. You have to work at it, and I'll tell you, this old idea of charging, he charges so much for orthodontics, that's like he charges so much to fix your car, regardless of what it is. It's stupid. These are tougher cases and take a lot more of your time and effort to go in there and do them, but there's a world of it out there, and we should Now here's this old partial frame, and we cut the Panorex here. It looks like this was in two pieces, but it's not. Now that's one we're going to discard, and we had it over this tooth, so I couldn't straighten this tooth up and use this. And I was working with this guy, and I think he made this, and I didn't want to throw it away or whack it off here and fix this tooth and pull it up and all that stuff, so I just left the tooth, and it'll work all right in that partial. But I wish I could have straightened that tooth out. All right, there's where the teeth met when we started, and here's where they were when we finished. In other words, we got the jaw came up here. This may have gone back some, but it didn't go back all that much. And now it's in class 1 relationship. And so you bring the jaw forward and let it close where it wants to, and that relieves most of these TMJ problems. If you don't have to go through all this rigmarole and all this stuff. I never used all that. And I went for 30 years with those TMJ things, and I don't think it had a single one we didn't help in there. You can't do everything in there, but we helped everybody that I know of. And here it was 11 of 90, and there it is when we finished up with the case. There's the jaw position there, and there it is after we positioned it. He put his new partial back in the back of his mouth, and there it is. There's the he definitely wears his retainer. You'll see the track like that in there. So you may wear it. You'd probably have the guy take it out and brush his gums if they're real good every day to keep it in good shape. And they've got a bite plate. His lower teeth fit into that groove right there, and they can't deepen, and that saves you. I mean, that keeps the jaw in that position. This is 11 of 90, and there it is, 3 of 96, and he has no TMJ problem. These teeth are staying nice and straight. I think I didn't show you that partial. Let me see if we go back to that. No. Okay, I've got a picture of the top of it, I know, in here. Here it is. Now, this is just a metal framework that fits behind these teeth. And these teeth can't move much. I mean, the anterior teeth are up here, and this is back here. So this is a partial and an orthodontic retainer at the same time, or a partial retainer and a partial. So that maintains those lower anterior teeth. And, well, there's a close-up. I knew I had a good picture of that. And so I had to show the dentist that was working with me on this. It was his patient. I showed him exactly what I needed, and he was able to do that for me. And that kept those teeth in place. And here was the man, excuse me, and I tell you, there's a world of this type of orthodontics out there. And there's just not too many guys that are doing this. And you work as a team, and whatever you need to get in there, you get a paradontist, or you get somebody that's an endodontist, and oral surgeons. I've done a good bit with oral surgeons. They would do part of it, we would do the other part. And like this, I just worked with the guy who was a good restorative man, and we got this fellow fixed up, and if he takes care of that, he can have these teeth at his funeral. And I tell you, I hope that many of you will join our little group here. I think I've got my picture all screwed up here. And we're in the American Orthodontic Society. If you want to learn orthodontics, now you can go in there with a general dentist or a pediatric dentist or paradontist. We've had people that with various specialties that want to learn some orthodontics. So thank you for listening, and I'm going to close this thing out now. Thank you very much. Bye-bye.